So, good evening, everyone. I welcome you all in the next session of GI and Hepatobiliary Oncology Webisode. And this time, like we discussed and talked about last time, that we will be discussing retroperitoneal and GI sarcomas basically. And we have divided this sarcoma into two sessions. One will be covering the systemic therapy radiation aspects of sarcomas, and second will be covering the surgical nitty-gritties basically. So we have amongst us esteemed faculty. We have Dr. Sameer Rastogi with us, who is a senior medical oncologist from AIMS. We have Dr. Nehal Khanna, who is a senior radiation oncologist from TMH. We have Dr. Udip Maheshwari, who is a senior medical oncologist from Mumbai Oncocare Center. And we have Dr. Sujeet Bhat, who is a surgical oncologist from Jammu. So all over India. So we have all esteemed faculty available, and I hope that we'll be enlightened and enriched by their experiences and their talks. So without wasting time, so Dr. Sameer, I welcome you to share your screen and start your lecture, please.
Yeah, thank you, Dr. Shefali. Is my screen visible?
Yes, your screen is visible. Yeah, full screen. Yeah.
So I sincerely thank organizers for the opportunity. And I'll start my presentation, which is retroperitoneal sarcoma. So I'll present in the following headings: the introduction, new adjuvant therapies, and advanced disease, how to treat it. So this is one of the most important slides, the distribution of retroperitoneal sarcoma. And the most common retroperitoneal sarcoma is D-differential liposarcoma, which is almost 1/3 or 40%. Then is 1/4 are well differentiated liposarcoma. Then leiomyosarcoma, which is almost 20%. Solitary fibrous tumor, which was earlier called hemangiopericytoma, and MPNST together constitute 10% of all retroperitoneal tumors. Other retroperitoneal sarcomas like undifferentiated pleomorphic sarcoma and desmoplastic small round cell sarcoma, they are quite rare. So based upon these pathologies, 90% of them are constituted in top 4, and we'll discuss mainly about these pathologies. So again, it's a multidisciplinary approach, and if we are seeing a retroperitoneal sarcoma, we need to know quite a few things about radiology, pathology as well. So the first primary investigation, which is usually ordered, is CT scan. And the first question is how to take biopsy. So there should be multiple core biopsies that need to be taken for diagnosis, and it should be taken from more solid areas of the tumor. And what exactly is meant by more solid area of the tumor? So I'll just show you. So suppose this is the pelvic liposarcoma. This part is solid part, and this is fat attenuated part. This fat could be normal as well. So probably it is important to take biopsy from more high-grade areas or more de-differentiated looking areas. Another thing is MRI is preferred if we are following a patient of Liposarcoma syndrome. As we all know, they should not be exposed to radiation. And Toronto Protocol explicitly says that MRI whole body should be done. Nowadays, PET-CT is readily available, and how to use PET-CT in the context of retroperitoneal sarcomas. So for biopsy, again, just like in CT scan, we search for more solid areas. For biopsy, we search for the areas with high SUV uptake, because they might be the areas of de-differentiation. Another indication, which is actually the first and foremost indication, is if we have some patient with neurofibromatosis, one with malignant peripheral nerve sheath tumor, then it differentiates between the malignant and benign part, because at times it is very difficult to differentiate between the benign neurofibromas and MPNST. I'll show in my next slides. And lots of time it seems that like a patient comes with well differential liposarcoma, and the multidisciplinary team is enthusiastic to operate it upfront without biopsy. That can be done, but in the setup of expert multidisciplinary tumor board, and if no new adjoint therapy is planned, so that we don't have to fight about grade later on. We don't have to think about altered diagnosis or altered pathology. So yes, biopsy can be avoided if we have imaging which is very much typical of retroperitoneal liposarcoma. So this is how a well-differentiated liposarcoma looks like. As you can see, these areas have same intensity as fat, and this is fat attenuation. You can see the septa, and so this probably this is the case which can be operated upfront without biopsy, which looks like well-differentiated liposarcoma because there is hardly any area of dedifferentiation. Again, this is a patient which I told earlier. This is probably dedifferentiated area, and this is well-differentiated area. They might coexist. Now, in neurofibromatosis with MPNST, how PET-CT helps? This is a patient who a young girl who presented to us recently with multiple neurofibromas. As you can see, these lesions, though apparently they seem to be FDG avid, but they are probably less avid than this retroperitoneal mass. So we preferably biopsied this patient from this mass, and it came out to be MPNST. We search for the areas which might not be neurofibromas, which might be malignant peripheral nerve sheath tumors. What are the differential diagnoses? So there are n number of differential diagnoses, but the most common in clinical practice and are more related to sarcoma, or there's more common are listed here. So germ cell tumor is one of the most important diagnoses. And recently we had a patient in which testicular swelling was missed on very first day, but next day our residents picked it and we got HCG was very high. Desmoid paraganglioma, desmoplastic small round cell tumor, and angiomyxoma. So again, imaging is very important. If you can see, this is a retroperitoneal mass, which is evident Dotanoff PET-CT, gallium Dotanoff. So this is nothing but it is paraganglioma. A retroperitoneal mass, which is Dotanoff, gallium Dotanoff avid, is probably paraganglioma. This is retroperitoneal fibromatosis, and as you can see, it is T2 image, and there is hypointensity, which is suggestive of fat fibrotic component. It came out to be fibromatosis. So, like coming from shifting gears from radiology to pathology, we need to have multiple core-needle biopsies from the different areas for the biopsy, and the expert sarcoma pathology cannot be emphasized. Looking at the fact that the discrepancy between expert pathologist versus non-expert pathologist is somewhere between 25% in the world's best center. And with time, with advent of more molecular techniques, with advent of more specialization ancillary techniques, this difference is almost widening. For liposarcoma, the minimal standard is MDM2. And on the discretion of pathologist, CDK4 and MDM2 amplification FISH can be done. Similarly, for solitary fibrous tumor, STAT6 is the minimal, but NAB2 STAT6 translocation or next generation sequencing can be done. While it is very difficult to get a grading based upon a small biopsy, however, if we have a good amount of tissue, then the grading should be done according to FNC LCC scoring, and it should be explicitly mentioned. So again, like rehearsing about types, we have told there are dedifferentiated, well-differentiated leiomyosarcoma, solitary fibrous tumor, MPNST. Radiology is of utmost importance. Pathology is the foundation of like the diagnosis and further treatment. Regarding neoadjuvant approaches, I think radiation would be a more apt, radiation oncologists would have been more apt to speak on this, but I've covered neoadjuvant radiotherapy. So to understand why we advocate neoadjuvant therapies in retroperitoneal sarcoma, first we have to understand what is the kind of recurrences that are observed. In well-differentiated liposarcoma and dedifferentiated liposarcoma, the majority of grade 2, the majority of recurrences are local recurrence, while distant mets are hardly there. However, in grade 3 liposarcoma and leiomyosarcoma, majority of recurrences are distant recurrences, and in leiomyosarcoma, local recurrences are hardly there. So this is it logical to think that probably leiomyosarcoma systemic therapy is more important. Similarly, grade 3 liposarcoma, systemic therapy is more important. While in well-differentiated liposarcoma, systemic therapy is hardly important because majority of recurrences happen locally. And as you can see, in 5 years, approximately only 20% recur. So the rate of recurrence is also slower as compared to their histologies. While SFT and MPNST, they are apparently better tumors than others because they recur less than other tumors. And the pattern of local recurrence is such that it never stops, it never plateaus, it just goes on with time. As you can see, it doesn't reach a plateau even at 3 years, it just goes on and on. So the local recurrence is one of the most challenging thing in retroperitoneal sarcomas because of anatomy and their size. What are the advantages of pre-operative therapy? Or let's be focused, pre-operative radiation. During pre-operative treatment, we have the tumor in situ and we can do gross tumor volume estimation easily. Similarly, the organ at risk, I mean, the tumor by itself acts as tissue expander, thereby displacing organ at risk and thereby avoiding toxicity. Tissue oxygenation because of present vasculature is better. Simultaneously, it is very well known that biopsy doesn't, in retroperitoneal sarcomas, unlike gallbladder cancer, doesn't do tumor seedling or consequent or subsequent peritoneal sarcomatosis. And post-operative radiation therapy, which is now outdated and not in vogue anymore, because in pre-op RT, there is small treatment volume. And once you have done the radiation, that necrotic tissue or the tumor has to be taken out. The volume delineation is easy, again radiobiologically superior, and since again that it acts as tumor tissue expander, so vital organs are spared. So there is very significant EORTC trial which was published in 2020, and so the only randomized evidence or prospective evidence before that was tried in one ECOSOG trial for which recruitment couldn't happen. Otherwise, everything was retrospective and biased. So this was the phase 3 randomized trial, open label and multi-center trial, in which randomization was such, this Strass trial, and after randomization, within 4 weeks, in first arm, surgery was done. However, in second arm, neoadjuvant radiotherapy was given mainly by 3D CRT or IMRT, and within 4 to 8 weeks, multivisceral en bloc resection was done. There were 266 patients, 133 patients in both arms almost. They defined their primary endpoint as abdominal relapse-free survival, which is a very clever endpoint because it doesn't take distant metastasis after surgery as compared to progression-free survival. So either it takes local recurrence or local progression before surgery and distant metastasis before surgery, or it takes local progression after surgery but it doesn't take distant metastasis after surgery. I mean, because that is the job probably, because for radiation therapy is mainly for local recurrence. And this is their patient population. As I said, this is first multi-center randomized trial which could randomize 260 patients, 266 patients, 133 in each arm. And the collaboration was quite appreciated. And if you see, majority of patients in this trial was almost 75% were liposarcoma, while leiomyosarcoma was only 15%, which is not representative. Others were hardly 10 to 11%. And there was one very surprising thing that almost in 25% of patients, the grade was missing, which again reflects that grading is quite difficult and sometimes very subjective in retroperitoneal sarcomas. And after neoadjuvant radiation therapy, 50 gray, the partial response was hard, as per RACIST criteria, was hardly 3%. Majority of them were stable disease, 82%, progressive disease was 16%, while 9% were not available. So they were all resectable retroperitoneal sarcomas. Response rate was not very significant so as to give radiation therapy in unresectable sarcomas and making them resectable. That means the response rate for radiation, maybe necrosis is higher, maybe local recurrences are less, but the response rates was not very high. And coming back to their primary endpoint, which was abdominal relapse-free survival, it was no different in both arms. It was almost 58% versus 60% at 3 years of follow-up. This 3 years of follow-up for retroperitoneal sarcoma might be a bit less of follow-up, which I'll cover further. However, as they did subgroup analysis, they could find that the main benefit was in liposarcoma group. They also did high grade versus low grade, and they found that probably it is more beneficial in low grade. And the benefit in liposarcoma was over and above 10% as compared to surgery alone. But the majority of patients were dedifferentiated, well-differentiated liposarcoma, for which 3-year follow-up seems to be very less, because they hardly recur at the rate of 4 to 5% per year. Probably a longer follow-up will tell us something new. They took grade 3 DDLPS, dedifferentiated liposarcoma. They took leiomyosarcoma also, and which don't recur locally very commonly, and which have higher risk of distant metastasis. Probably if they would have taken grade 1, grade 2 dedifferentiated liposarcoma and well-differentiated liposarcoma, maybe the benefit would have been there. There was no central assessment of surgery. I mean, all the institutes have had different expertise. However, they were all institutes from Europe and US, so probably their quality was up to the mark. They were missing data for grade. And during their sample size calculation, they thought that there would be 20% absolute difference between neoadjuvant radiation and with no radiation, which was a bit too much optimistic, this assumption of 20% absolute difference. So, but still long-term follow-up is awaited, and let's wait for long-term follow-up this. But learning from this trial, thinking that probably for dedifferential liposarcoma high grade and leiomyosarcoma, the recurrence chances are more for distant. Now STRAS-2 trial has begun recruitment, and STRAS-2 is neoadjuvant chemotherapy. For liposarcoma, they are giving doxorubicin plus ifosfamide, while for leiomyosarcoma, they are giving doxorubicin plus dacarbazine. And again, just like STRAS-1, they will, after 3 to 6 weeks, they'll do surgery. But they haven't taken low-grade histology. This is a wiser step, and the recruitment is on. So if a retroperitoneal sarcoma high grade is now diagnosed in their country, they probably recruited for the STRAS-2 trial. There are few drawbacks of neoadjuvant therapy. We had few experiences where it was diagnosed MPNST at baseline, and after surgery, it came out to be SFT. And similarly, the histology might change. That means the pathology has limited tissue. The grade is again, once on a basis of small biopsy, it is very difficult to tell the grade, and always pathologists tell us that to take more tissue. And with no guidelines in place and with the evidence STRAS trial, if a patient progresses from resectable to unresectable, it is too difficult to back it with the evidence right now. But maybe STRAS-2 trial succeeds. So I've covered neoadjuvant approaches. Neoadjuvant chemotherapy is still in STRAS-2 going on. STRAS trial failed for its primary endpoint, and there are quite a few retrospective studies, but post-STRAS, the emphasis on retrospective studies has almost gone. What about adjuvant therapy? So I've attended quite a few tumor boards of transatlantic retroperitoneal sarcoma working group, and right now they are not advocating any adjuvant therapy. And the guidelines reflect this. Post-operative radiation after complete resection is of no benefit and is associated with short-term and long-term toxicity. Again, few retrospective studies are there which say that it might be beneficial, the local recurrences are decreased, but right now there is stance and all over what the practice is not to give any adjuvant radiation. Similarly, adjuvant chemotherapy, right now there is no evidence to give adjuvant chemotherapy. I don't know about radiation, that like how people here practice, or it might be a subjective difference in practice, but for chemotherapy, I make it a mutual decision-making discussion. And I'll just tell you how. I mean, this patient presented to us with this large retroperitoneal mass, and it was operated. It was almost 15 centimeter. And again, this is SMA positive. This is MDM2 positive. As I said, MDM2 is must to be done. and it was D-differential liposarcoma. So we use nomograms, which there are quite a few nomograms, MSKCC nomograms, circulator app, and grohedal nomograms. And if it is grade 2, the risk of recurrence is 50%, which is quite high. And if it is grade 3, the risk of recurrence becomes almost 70%. So while extrapolating these histologies, that maybe if had it been extremity, I would have given chemotherapy, then probably I give them an option that data is not there, but chances of recurrence are overwhelmingly high, especially in leiomyosarcoma where, or dedifferentiated grade 3 liposarcoma where the chances of distant recurrence are quite high. So based upon this mutual decision making, we give chemotherapy. Regarding post-operative chemotherapy, the only challenge we focus is a lot of time these patients have had post nephrectomy, and that causes ifosfamide can be very difficult to administer post nephrectomy. And even looking at this STRAS trial, when the patients were resectable upfront, almost 80% of patients in surgery arm had kidney resection, which is a quite high percentage. Regarding follow-up, as of now, the recommendation is that we have to follow them indefinite. And again, coming the most important thing during follow-up, the kind of recurrences have to be seen. I mean, for well-differentiated liposarcoma, probably I'll go for CT abdomen only, no CT chest. For dedifferentiated and dedifferentiated grade 2 and 3, we'll go for both distant and local imaging. For leiomyosarcoma, I'm more worried about distant imaging, but nevertheless, I'll cover local imaging as well. And for high grades, we'll go for 3 to 6 monthly follow-up, because even small recurrence, probably we can catch it at earlier stage in absence of evidence, and we can operate it and make it curative again. So here I cover adjuvant therapies for which the role evidence as such is not there. Guidelines strongly refuse them, but we can still make decisions patient to patient basis. What about advanced disease? So this is histology tailored approach in retroperitoneal sarcomas. As you can see, for leiomyosarcoma, chemotherapy, doxorubicin based, docetaxel, gemcitabine, and pesopenib, trimectidine, eribulin. These are the options. Eribulin is not FDA approved, so that's why asterisk here. Liposarcoma, these are the options. MPNST, chemotherapy and pesopenib, but however, or gemcitabine, docetaxel, but trimectidine can be used in neurofibromatosis associated MPNST. SFT, vascular agents are there, and immunotherapy is also promising, but to a subset of patients, and I'll discuss those subsets as well. So this is how and where these therapies work. Pesopenib, which is anti-VEGF, anti-PDGFR receptor, this molecule. Trimectidine works at DNA level, eribulin at mitotic spindle. Pesopenib is approved for non-adipocytic sarcomas in second line post doxorubicin based therapy, and the median PFS benefit was almost 3 months. It is a well-tolerated drug, so after chemotherapy is exhausted, we often use it because of its good tolerance, and simultaneously majority of patients end up with stable disease. Then trimectidine is approved in second or third line for L sarcomas, both liposarcomas and leiomyosarcomas. The trial in which it was approved, the registration trial, was compared with dacarbazine, and again there was 2-point-something month benefit median, but some patients, it is a non-cumulative drug. Some patients do very well for even years. Eribulin is approved only in liposarcoma, and this is the only drug of all these drugs which could improve survival in the given trial. However, the data after that trial is sparse. Only one registration trial was there. Nonetheless, it is FDA approved for liposarcoma, and the median survival in eribulin arm as compared to dacarbazine arm was almost 2-month benefit. So this is one of our patients with D-differentiated liposarcoma. And as you can see, this is pre-trimectidine and this is post-trimectidine. The patient is still almost 7-8 months after trimectidine start, and it's going well. Trimectidine is non-cumulative. For a fraction of patient, it can be wonderful drug. So we had a patient with solitary fibrous tumor. This is STAT6. As I said, for solitary fibrous tumor, STAT6 is mandatory. And this patient had pelvic mass. This patient had liver metastasis. And he progressed on pesopenib chemotherapy, and we started on axitinib and temozolomide. For axitinib, the data is coming, and temozolomide data is also there. And as you can see, the liver metastases have almost metabolically disappeared. I mean, morphological, they were there, but there was complete metabolic response. It's been almost 1.5 years for this response. What about immunotherapy? We always say that immunotherapy is very promising. So let me tell you, it's not promising, but in a fraction of patients, again, it can be a boom. So the initial study, which started in 2017, that they took 40 patients, and out of 40 patients of 10 each for UPS, liposarcoma, undifferentiated pleomorphic sarcoma, and synovial sarcoma, there were majority of responses were in UPS arm, undifferentiated pleomorphic sarcoma. While in liposarcoma, 2 responses were there. Leiomyosarcoma, it failed in SARC-028 study. However, they increased the cohort from 10 to 40, and they again found that in D-differential liposarcoma, there was some response rate of 39 patients, 4 patients responded, which was much below their expectation. And so it was deemed to be non-appropriate for liposarcomas. And all 3 patients who responded had PD-L1 negative. So no one knows which biomarkers are to be used for these. Like if we want to have somewhere between 9-10% response, which biomarkers can be beneficial to guide appropriate immunotherapy. But it works in liposarcoma, response rate is 10%. Unlike undifferentiated sarcoma, where the response rate is 25 to 23%. This is our paper, which was published this year with immunotherapy in sarcomas. We had almost 15 patients, and 3 of them had liposarcomas, and 3 were retroperitoneal sarcomas. And this is one of our patients with the retroperitoneal sarcoma. This is retroperitoneal mass, the baseline presentation 2017. The patient also had Liefeld syndrome. And later on, the patient was given gemdosi, doxorubicin, dacarbazine, Trimectidine, eribulin. However, post that patient had multiple masses, and we were pushed to the wall, and we got tumor mutation burden, and it was very high. It was 23, which is very unusual in sarcomas. And after that, we started pesopenib, and the response was dramatic. As you can see, the metabolic uptake in all these lesions, and this is after post 1 year of pembrolizumab, and the lesions were hardly there. There are almost metabolic response. So probably immunotherapies will be beneficial in those patients who have high tumor mutational burden. Maybe PD-L1 might help, but it doesn't help usually in LPS. And more papers are coming every year. They are now focusing solely on immunotherapy. So let's hope something comes up which is well worth it. So so I think we have discussed about the pathology, radiology, new adjoint approaches, adjoint therapy, and the targeted therapy and immunotherapy, which might be beneficial, but just for a fraction of patients. Thank you. I'll be happy to answer any questions.
Yeah, thank you, Dr. Sameer, for a very nice and crisp presentation. I think summarizing sarcoma is a very difficult task. So you did it very well. So a couple of questions. So do you think there is a role of NGS at any time point in sarcomas? And if you wish to do it, where should we place it actually?
That's a very relevant and practical question. So there was a study by Mrinal Gundar, who is in MSKCC, where they did NGS for 2 things. One for improving the diagnosis, and one for getting the targetable mutation. For diagnosis, only 2 to 3% extra they could achieve with NGS. This was foundation 1, which has so vast genes, and even MSKCC relied on that. But for therapy, they could hardly get any targetable mutations. They say they got in 20% or 30%. But for many of them, drugs were not available. But FDA approved were hardly 6 to 7%. Even for them, the response rate is not there. Regarding TMB is high only in 2 to 3% of patients. There is ample literature. So, you want NGS for the mutations which are there. The targetable mutation in sarcomas would be probably NTRK. So NTRK would be like 1 to 2%. You are looking for MSI high, which is probably 2 to 3%. If we want to get it done, it has to be a comprehensive lab which covers NTRK, which understands that RNA is important and NTRK1, 2, 3, I mean, it should be there, but the chances of getting anything is so less that we need to talk to patient before advising it, because 3 lakhs worth, this is very difficult.
Right. And just a little out of track, but is there any upcoming or any defined role of HIPEC in retroperitoneal sarcoma surgeries? If you see, and how is your approach in basically GI sarcomas who have extensive peritoneal disease per se? Though it is a rare occurrence, but I mean, do you really discuss and think about, give it a thought if some patient requires this?
Yes, for HIPEC evidence, there are 2 or 3 papers from Vivek Subbiah, MD Anderson, and their majority for desmoplastic small round cell tumor. If there is some retroperitoneal sarcoma, in fact, MSKCC paper is also there, in which they first did HIPEC, they gave chemotherapy, they gave radiotherapy, and they gave some radioisotope of iodine as well, and they found that their recurrences were very low. But for routine sarcomas right now for HIPEC, it's not there. Even for desmoplastic small round cell tumor, they calculate something called CRS, and I think it has to be something very less. So I probably right now, other than very localized desmoplastic small round cell tumor, HIPEC is as of now not recommended much.
Right. And I think there are no questions in the chat box, so we'll move on to the panel discussion. So I invite Dr. Devavrat Arya, who is our Senior Director Medical Oncology in Max Arcade, and who will be moderating, who is actually looking after sarcomas in our DMG, and he'll be moderating the panel. And the panelists esteemed faculty are Dr. Nehal Khanna, Dr. Udip, and Dr. Sujeet Bhat. So Dr. Devavrat, please take over. Dr. Rastogi, can you please little stop sharing so that he can share his? Yeah, all right. Thank you.
Yep. So thank you very much, Dr. Shefali, for the introduction. Let me just quickly get my presentation ready. So just 1 second. So are my slides visible?
Yeah. Yeah, okay. Full screen is visible.
Yep, thank you very much. So I think Dr. Sameer has already done an excellent job of summarizing the evidence and in some situations, the lack of evidence when you treat sarcomas, and particularly when you treat retroperitoneal sarcomas. And I think that's made my job a little easier. But nevertheless, I think it's very important to discuss how we apply the evidence of lack of it in our day-to-day practice and how we approach each individual case of retroperitoneal sarcoma. So let me very quickly invite my panelists. So I have Dr. Nehal Khanna, who's a renowned radiation oncologist from Tata Memorial Hospital, Mumbai. Dr. Udip Maheshwari, who's a medical oncologist associated with Mumbai Onco Care Center, again, Mumbai. Dr. Sameer Rastogi, kindly join us. It's Dr. Sameer, obviously, is from All India Institute of Medical Sciences, Delhi. And I'm not sure if Dr. Sujeet Bhat is online. Dr. Sujeet Bhat is a surgical oncologist from American Oncology Institute in Jammu. So I'll request all my panelists to keep the camera on. It's slightly easier, even though it's a virtual platform, it's slightly easier to be able to see your faces and interact. So I hope all the panelists.
I can't see Dr. Sujeet Bhat's name, but I don't know whether he has joined from some other.
Okay. Yeah. Dr. Nehal, are you there?
Yeah, Dr. Hello. Nehal is there. Yeah, I have seen him.
And
Dr. Nehal, please unmute.
Yeah, and kindly switch on your cameras if possible. And Dr. Udip as well. Dr. Udip, are you there?
Yes, I'm there.
Okay. So I think then I have just 3, Dr. Nehal, Dr. Udip, and Dr. Sameer. So I think quickly moving ahead, we know how rare retroperitoneal sarcomas are. We know that there's no one-size-fits-all approach. We know they are complicated diseases. Typically, they are large. There are anatomical complexities. While surgery is the standard of care, R0 resection often is very difficult, if not impossible. And then role of neoadjuvant and adjuvant chemo radiation is very debatable at best. And I think what we've seen in different centers of excellence is also the fact that there is a variation in practices, and there's a lot of difference of opinion. We've seen Dr. Sameer talk about the data regarding how retroperitoneal sarcomas have a propensity for local recurrence rather than metastatic spread, particularly for the lower grade ones. And while complete surgical resection remains the therapeutic goal, R0 being impossible at times, and we also know that those patients who undergo a surgery but have an R1 resection, large observational studies that seem to suggest that local recurrence and eventually overall survival is worse for these patients. So quickly a case. So this is a 62-year-old gentleman. He's a diabetic, presented with epigastric discomfort and bloating for the previous 2-3 months. No history of weight loss, increased frequency of urination, abdominal lump felt for the past 2 to 3 months. And then on examination showed a large mobile lump in the lower abdomen. Undergoes CT, MR, and PET. So I've summarized. So the PET scan showing a large abdominal mass in the lower abdomen, which is encasing and compressing the IVC, aorta, and bilateral common iliac veins. There are also some centimetric size right hilar node. Biopsy with IHC eventually shows a leiomyosarcoma high grade, and it's suggestive of differentiation. And this is the MR. Now, I know we don't have a surgical oncologist on board, so I think this is more for the sake of completion. But again, this is a huge mass, as most retroperitoneal sarcomas are. So 18.5 by 15.5 centimeter size lesion, and 21 centimeters in craniocaudal length, predominantly retroperitoneal location, extension along the route of mesentery. Post-contrast images reveal moderate heterogeneous enhancement with multiple non-enhancing necrotic areas, encasing aorta, inferior vena cava, displacing it and encasing the branches. Left ureter is encased. There's an upstream left hydroureteronephrosis. There's edema in the left renal parenchyma. It's in contact with the third part of duodenum. There's a lot of loss of intervening fat plane, displacing small bowel loops. And there's also contact broadly with the L3 to L5 vertebra, indenting the urinary bladder, although there's no invasion of the bladder. Sigmoid colon is displaced, but there's no infiltration. And there is a 1.8 centimeter rounded lesion in the subcapsular part of segment 6. And it also looks like metastatic, but for the time being, so we will ignore the liver mets. And this is how the PET scan looks like. Again, I think this is very relevant to the surgical oncologist and the radiation oncologist. It's also relevant to the medical oncologist, and we come to the question why. Now, so let's presume, and since Dr. Sujeet is not there, let's presume this is operable retroperitoneal sarcomas. Let's presume that this is not a leiomyosarcoma. Let's presume that's a low grade or a grade 2 liposarcoma. So I'll very quickly come to Dr. Nehal, and I've tried to make it easy. So Dr. Nehal, we've looked at the evidence. We've looked at some of the evidence, particularly STRAS trial. How do you see the role of preoperative RT? What is the rationale? And I'll add the question: if you are going to offer a preoperative RT, what are the factors do you look at? Histology, size, and particularly resectability.
Am I audible?
Yes.
I first thank you all for inviting me to this panel. Role of radiation, we all understand, is very controversial, and equally controversial is the sequencing of radiation in retroperitoneal sarcoma, whether pre-op or post-op or even intra-op like IORT. So if I was to just compile the evidence for radiotherapy, yes, we have multiple publications which have shown that radiation does have an impact on local control. There are certain population-based studies like the SEER database, the National Cancer Database, the Alberta Cancer Registry. There was one, if you talk about only randomized trial, there are only 2 randomized trials which address the question of radiation. One is intra-op radiotherapy, which showed that the local recurrence, the difference in local recurrence with radiation, it was almost 3 times. It was, I think, 20 versus 60. So in patients who were given intraoperative radiotherapy, a single sitting of 20 gray, there was a significant reduction in local recurrence. But if you look at intra-op radiation, it is not available everywhere and it has very limited accessibility. And that was just one trial which showed, yes, this is the one.
Yeah,
So I actually do not give that much of importance to this trial, though this is a positive trial. But if we come to STRAS trial, everyone, when they have a presentation, the surgical oncologist, the medical oncologist, it looks like STRAS trial is the last nail in the coffin of radiotherapy for retroperitoneal sarcomas. But if you read the STRAS trial, being a radiation oncologist, I've dived into the protocol, the methods that they have used, the definitions that they have given. There we have to understand that there are very major, I will not say fallacies, but limitations in the design of the study. Why do we need to give pre-op RT? We need to give pre-op RT to reduce local recurrence. What do you mean by a local recurrence or a local relapse? Once you completely remove the tumor, the patient is disease free, and after some time the disease comes back. All of us understand this as local recurrence, right? But the local relapse, local recurrence that was defined in this study was a very comprehensive definition. In fact, I should not call it comprehensive. This is in fact more bizarre, and they wanted to include almost everything as local recurrence, like local or progressive disease during pre-op RT, inoperable, yes, R2 resection, peritoneal mets, inoperable disease. So, but if you look at the true local recurrence in the STRAS trial, with the use of radiation, there was a 50% reduction, more than 50% in fact. If I remember correctly, 37 versus 14 or 17, I don't remember exactly, but more than 50%. Yes. And this was for the whole group. And then when we come to the specific group of liposarcomas, it was shown to have benefit. So I will not say that we should, outright just say that, there's not much of role role of preoperative radiation in retroperitoneal liposarcomas. I think this was a landmark study. A study like this cannot happen. But with this transatlantic retroperitoneal sarcoma working group, we are now able to understand, we have a larger, even retrospective, just 2 years before this study came in, Rick has had through this group, actually wrote a very nice article on the role of radiation. And he also showed in, I think, 800 patients of the centers which were collaborating with the transatlantic group, that radiation has a role. So now if you ask me that, yes, I'm pushing forward for radiotherapy, what are the criteria that we use? So in TMH,
so
yes, we have used.
I'm sorry. Let me just interrupt you here. So
yes, I'm sorry I spoke a lot, but it was important to.
It's okay. Yeah, you raised the relevant points, and that's why I didn't interrupt you.
Yes.
Now the issue is, right? Obviously, the abdominal recurrence-free survival is a very unique endpoint, and I fully agree with you. I think it's not an endpoint that is often used. You are absolutely right that local recurrences were higher with surgery alone, and local recurrences were much lower when radiation therapy was added. We do know that while OS was a secondary endpoint, there was no improvement in OS. What's also important from this trial is that 16% of patients actually had progression during radiation. And remember, these were patients who were resectable at baseline. This was the criteria. The patient needed to be having a resectable disease, although majority of these patients who did progress eventually were able to undergo a surgery. So high progression rate, 16% is a big number. You had a fairly high number of adverse events, grade 3 adverse events of about 24%. And I don't think they were able to measure, post-op morbidity, particularly in those patients who had radiation. So with those figures in context, how do you see those figures? Yeah.
So I'll come back to the first point when you said that there were patients who progressed on RT. This exact number of patients that progressed on RT were 19. And if you look at it, 3 had distant metastasis. Now, those are, in fact, I would feel is more determined by the histology. 1 patient had shock, but the remaining 15 were operated. There was complete resection achieved. So with radiation, at times it happens that there is more of necrosis. Look, we have to understand, sarcomas are not radiosensitive tumors that, you know, you will actually see a visible shrinkage in the tumor size. What happens is, for example, we use preoperative radiotherapy so often in extremity sarcomas, and it is seen that when you operate these patients, I'm not extrapolating the same data, but if you see, the tumor develops a nice rim, and the chances of not just tumor spillage, but, you know, contamination at different planes also reduces. So when we say that these tumors progressed, we have to really see in context of what? When they progressed, not a single patient became inoperable because of the size or the increase in the extent of lesion. They have a table, I think, at the end of the paper, which actually summarized those 19 cases. 3 had distant metastasis, 1 had shock, but remaining 15 were operable with R0 resection. So it's a very important point that needs to be clarified.
So, but then does that mean that all the patients who have a well-differentiated liposarcoma or a grade 1 or grade 2 liposarcoma, are you happy offering radiation? Is there a size cutoff? You know, how would you, you know, talk to your surgical oncologist and convince him or her that, you know, the case should be taken up for pre-op?
Yes. Dr. Devavrat, I think this is the most apt question here, that if at all, you know, you want to approach, how would you approach? So I would say that it's like exclusion. Certain cases I would not want to consider RT. For example, a leiomyosarcoma, I would not want to consider RT. In a grade 3 dedifferentiated liposarcoma, I would not want to consider RT because distant metastasis in these cases is significantly high. But when you talk about grade 1, grade 2 dedifferentiated liposarcomas, when we know local recurrences are high, even well-differentiated liposarcoma, Dr. Sameer actually very beautifully mentioned in its study that they have a very steady rate of local relapses. You know, we have to understand these patients are going to recur. This histological subset is going to recur locally, and these are not simple surgeries. These are difficult surgeries. And once a patient relapses, you know, these patients are bound to have a second and a third relapse. And when we talk about toxicity, you know, adjuvant radiotherapy, even preoperative radiotherapy, I feel there is a, you know, lack of understanding as to how. So in quite a lot of centers, adjuvant radiotherapy is not given. The surgeon feels, oh my God, you know, iska to the entire abdomen was full of tumor. We cannot offer radiation to the entire abdomen. No, there are contouring guidelines. There are consensus consensus documents available in which radiation is offered only to sites which are at high risk of recurrence, the tumor bed, the place from which the tumor was arising from. So in fact, these are the sites where I would say that yes, we should offer. I would weigh preoperative RT and postoperative RT equally in my treatment decisions. I would say if it is upfront resectable, it is not going to cause significant morbidity or a huge compartmental or a visceral resection, we should try and offer neoadjuvant radiotherapy. But in upfront resectable cases, in post-op situation, if the tumors are large, if they are recurrent tumors, if the margins are close or margins are positive, we should offer adjuvant radiotherapy with conformal portals, which has much better tolerance.
So you mean to say that for pre-op, can you repeat your point? I think you made a very important point. Who again are the?
I would not give.
You will not give to.
I will not give to high-grade leiomyosarcomas. I would not
that point is
prefer to give to grade 3 dedifferentiated liposarcomas, but for grade 1, grade 2 dediff lipos and well-differentiated lipos, and obviously other histologies, even MPNSTs and synovial sarcomas, I would consider neoadjuvant radiation.
Okay, and what about dose? Are you happy with the dose that was offered in the STRAS trial? Do you use different doses?
Yes, we don't use different doses. Yeah. So our aim, we give 50 gray neoadjuvant dose.
Right.
And with conventional fractionation, There are certain studies going on which are evaluating hypofractionation and early surgeries, but the data is very premature. I would not comment on that. So around 50 gray, essentially not to cause tumor shrinkage, not to achieve any kind of tumor response, but to sterilize the tumor periphery is what the intent is here. So that chances of R0 is easy, chances of an easy surgery is possible, and chances of getting a margin negative is also a possibility.
So in your practice, if you have 100 patients with a borderline resectable RPS, I know it's a difficult question. What percentage do you think, are able to undergo R0? Do you have a ballpark figure?
No, I would not know, but I must say that we have very enthusiastic surgeons in our team. So
right. And what about proton and flash?
Can I interject, please? I have a question.
Yeah, come in.
So
yes, Dr. Sameer.
I don't know if these transatlantic retroperitoneal working group guidelines you have read, or if you have attended their tumor boards. They have weekly Friday tumor boards. And
I know, I have not been able to do that.
Dr. Grahi, you talk to Dr. Chandrasekhar, and a lot of people there who are practicing retroperitoneal sarcoma exclusively.
Yes.
And we have discussed lots of cases, and they just tell us that right now, absolutely. We have like absolute this.
For adjuvant RT, they are very much against adjuvant RT.
In Europe, at any center, post-op radiation is never done.
Post-op
radiation, they have stopped doing because of failure of this trial. They are doing only, this is practice, it's not a bias, but right now they are only recruiting their patients to STRAS-2 trial. That's what they are banking on. That might fail completely. But if you, any one of them, we have patients who mail these people and they just tell us no. Because guidelines,
I completely agree with you. So there is a very strong lobby. Yes, there's a very strong, lobby is not a very positive word. I'm not able to come up with the right word. But yes, there are a lot of surgeons who do not prefer giving radiotherapy. But, if you literally dive into the evidence, these are uncommon tumors. We will never have a strong evidence. And looking at the STRAS trial, I started my point saying that, they have actually considered STRAS trial as one of the last nails in the coffin for radiotherapy. But if you read that trial in detail, you would in fact see that that trial emphasizes, the results of that trial have actually emphasized the role of preoperative radiotherapy in a select group of patients, which is actually a very win-win situation. But unfortunately, it is not highlighted. It is
I'm sorry, I'm coming in here. I'm really sorry. I need to interject here. We all know the conclusions of the study. I think broadly we know that this was a negative trial. We also understand that the STRAS-2 is actually enrolling what are considered chemosensitive subtypes or subtypes which are capable of metastasizing, and we'll come to what exact inclusion criteria they have. But I do agree that there are two ways of looking at this study. One way is to see it as a negative study. The other way is to look at select grade 1, grade 2 large liposarcomas and say, yes, while it did not improve abdominal recurrence-free survival, it did improve the recurrence rates locally. And that's a good enough reason to continue the way practice is continuing. I fully agree. Adjuvant radiation is probably a no-no in most settings. And I think we'll discuss this a little bit more later. But just for the sake of completion, Dr. Nehal, we hear a lot about proton. We hear a lot about flash. Do you see any role of these strategies? We know how difficult it is to radiate in the retroperitoneum. Do you see any studies? Do you foresee some data coming in the future saying that this is making radiation easier or more effective?
Flash, I would not like to comment because it's extremely premature. But yes, proton, definitely we see. There are a couple of studies going on with external RT itself, wherein along with the preoperative radiotherapy, the tumor bed where they feel that the chances of local recurrence is high, they are actually giving higher dose. So there is not much of difference between proton and the external beam radiation that we use, the photon based. The dose equivalent is much more in heavy ions. Proton is not a very heavy ion, but it does help us with escalating the doses and limiting the toxicity. It has a very big advantage in these 2 points. So in fact, in TMH, we are going to have a proton soon, and we are in the process of writing an article, not an article, but a project for retroperitoneal sarcomas, escalating the doses with protons. At the same time, limiting the toxicities.
Right. So possibly a role, but I think in the realm of further investigation and flash, you've not commented.
Absolutely.
I'll come quickly to Sameer. Sameer, what's the practice? I think we heard Dr. Nehal saying that while intra-op RT is an option, we also understand that it's not an easy option and most people are not doing it. What's your take? Is intra-op RT happening in retroperitoneal sarcomas at your center? And again, the other question is, we have some literature to say that it is feasible to combine chemotherapy concurrent with radiation. All of us are very skeptical. I am very scared. I know you've done CTRTs for extremity soft tissue sarcomas. So your take. So 2 questions for you.
So before, I was very pro radiation before STRAS trial. There was a paper by Nussbaum in Lancet. It was SEER database review, and I think thousands of patients were there, and they showed that the preoperative radiotherapy increased survival, and that survival, this one. I was so fascinated by this study that, I used to think that this is the, preoperative radiotherapy is definitely, but again, once things happen in randomized setting, and once, after STRAS, again, I agree with Dr. Nehal also that, but we now don't use radiation. We now, unless or until like patient is very high risk for recurrence, huge tumor, and patient wants to take GI toxicity. Then patient says that they are okay with this, and our radiation oncologist gives. But otherwise, my take is usually, because we discuss these are patients in tumor board, this transatlantic one. Anyone can join those tumor boards, and probably the people who are there, lot of people are there, lots of people, and they always tell the radiotherapy right now is probably not right choice. So we don't give, and if you read this transatlantic retroperitoneal radiotherapy has no role. Neoadjuvant, they can give probably. It decreases in low grade. However, this is not proven. So in low grade, if in well-differential liposarcoma, suppose it is recurring at rate of 4% per year, then I understand probably in 10 years, 40% will recur and 60% will not recur. So giving radiation to everyone, and if you read NCCN guidelines, they say that radiation therapy should not be used routinely, except in some exceptionally circumstances where high mortality, high morbidity. So it is very difficult.
So you told us that in your mind, the large sarcomas, those with high risk of recurrence, and particularly for those patients who are capable of taking the GI toxicity, are the ones that you would actually use as those exceptional cases
if,
where radiation.
If my radiation oncologist is saying, then I can just maybe concur with them, but otherwise, no. But problem is this: if a patient reads NCCN guidelines or they say any guidelines, then if they question me why am I using in well differentiated low grade, there is nothing to tell them. The evidence is not there. So
right.
Not very.
You're absolutely right. I think that's unfortunately the truth with retroperitoneal sarcoma. So coming quickly to the other question, no intra-op RT at AIIMS or any fans of intra-op RT at All India Institute? Dr. Sameer, you're not audible.
Yeah. So I said no intra-op. Radiation is no.
No, and no CTRT, right? No CTRT at all.
No CTR in retroperitoneal CTRT. I don't even know that if it is given, because the toxicity would be so difficult. We give an extremity pre-op CTRT, but here though I don't think. Though our radiation oncologist says that post-op RT in current technique doesn't cause this much of complication. Even papers are there, but I don't know. We are not able to do that regularly. Post-op RT, I'm still not. I am maybe biased or this. I don't practice.
No, absolutely. I think you made a fair point. I see there are two sides of the coin, and unfortunately, when you have just one trial which is accrued and which has a very complicated endpoint, there are different ways of interpreting the data, but I think the idea is to select the right case, and that selection criteria may also vary depending on where you are practicing, what techniques you are adopting, how much time you are able to give to the patient, how understanding the patient is, and how capable the patient is of tolerating the adverse events of any modality that you're offering. Now, coming back to the very beginning, this was eventually a leiomyosarcoma and not a liposarcoma, and we know that leiomyosarcoma have much higher metastatic potential as compared to the other ones. So, Dr. Udip, I have not been able to involve you so far, so I'll start with you. How do you see the role of neoadjuvant chemotherapy? In your mind, what would be the histologies that you are willing to give neoadjuvant chemotherapies to, and what regimens do you prefer? I know these are 3 questions, so you have them on the screen.
Yeah, so I go with, so if it's a LMS, right? So as you said, leiomyosarcoma, we usually go with gemdosi, and since we are a daycare unit, daycare chain, gemdosi becomes our primary chemotherapy regimen, which is simpler, easier, tolerance is good. All these, such a big tumor, the tolerance also plays an important role. So I go with gemdosi in most cases, excepting a high grade leiomyosarcoma, or a high grade LPS. We go with there we go with IA. So also the treatment decisions are dependent on the patient profile and how the patient's general performance status is. So that is one. Second question. What was the second question?
How many cycles would you do before doing a
So 3 cycles. The basic aim is to see how clinically the patient is responding. So if beyond 2 to 3 cycles is what we aim at. If the patient is symptomatically not responding by 2 cycles, we tend to reevaluate at 2. If patient has good clinical symptomatic relief at 2, then we tend to give 3 and then respond. So the peak response that we achieve mostly is 3 cycles. But yes, we keep a low threshold for reevaluating these patients, because there are around 15 to 20% of the patients who will not respond and will progress, and we may lose the opportunity for surgery.
So how confident are you? Often your surgical oncologist would refer the patient to you. I know the criteria of resectability and unresectability varies across surgical skills as well.
Of course, absolutely.
Now, how confident are you? I know when a patient is referred to me for neoadjuvant, I would certainly look at the histology and see whether it's chemosensitive or not. But I accept all these patients with a lot of skepticism, looking at the lack of data and looking at the fact that they are mostly retrospective studies. How confident are you?
So in high-grade tumors, I'll tell you. So we have treated a lot of LMSs, and in leiomyosarcomas, there are good response rate with gemdosi. I will, but then do they tend to change survival? Is something that I don't have an idea of. Yes, do they achieve operability? Yes, operability becomes slightly better. Whether they can be completely operated is something difficult, and we have to tell the patient that these therapies are something that is not are rare tumors, and we don't have enough evidences to definitely tell you what will happen. But yes, 50 to 60% response rates is what I see with high-grade sarcomas, and LMSs I usually get a lot of good responses. So recently I was treating a round blue cell tumor, and we started with a higher dose ifosfamide, adriamycin, and platinum dose, and he was absolutely packed with ascites and a non-measurable disease in the abdomen, a young 28-year-old male. And with 1 cycle, his ascites is completely gone. His disease is almost 30-40% reduced. And with the second cycle, now I have escalated the dose of cyclophosphamide to 3 gram. There is a paper for high dose cyclophosphamide in this particular regimen. And we have used that regimen. And now he is going to be evaluated for CT and surgery for a CRS. And probably a patient who looked almost at a dead end has revived, and probably he may undergo a very good surgery. So I have enough confidence on chemotherapy, yes, but the histology selection should be apt. Low grade, dedifferentiated, they will definitely not respond.
So I'll quickly come back to Dr. Sameer. I hope you're still online. I see you online. Dr. Sameer, your thoughts. What are the patients you're doing chemotherapy for? What are the criteria? What cycles do you do? A histology driven therapy. I use a lot of dox-DTIC for my leiomyosarcomas.
No,
I
that is
don't use
perfect.
it.
Everyone is using doxo-DTIC.
Yeah.
Doxo-DTIC is like word has shifted from ifosfamide to this.
Right.
So
Right.
this was, I mean, they did not use doxodecarbazine. These people, they use gemdosi or some other gemdecarbazine.
This is TRAS2. So
these people, Italian people, for this histology tailored therapy.
Yeah.
They use
So
gemdecarbazine. In TRAS2,
Yes,
I also use doxodecarbazine. In fact, one of our patient is common osteosarcoma and leiomyosarcoma, bone leiomyosarcoma, and excellent response on doxodecarbazine. So we use it. It is less stressful, less toxic, and probably equally effective. A lot of people use it.
And IFOS probably is not so effective in leiomyosarcomas.
Yeah, same.
So these are the criteria, and I know this is still in the realm of a clinical study, and you've already discussed what they're trying to include are the higher grade tumors. So we're talking about grade 3 dedifferentiated. We are talking about leiomyosarcomas, and they actually are looking at specific criteria. So leiomyosarcomas have to be grade 2 and 3. Minimum size has to be 5 centimeters. Liposarcoma, they need the IHC confirmation. All grade 3 and select grade 2 can also be included. And what they're trying to do is treat for 3 cycles. I think LMS is dox-DTIC. Liposarcoma is IFOS doxo, again 3 cycles. And then they do an evaluation, and if feasible, they do a surgery. So
can I ask you one thing? I just want to interrupt. Sorry.
So I'm the moderator. I don't answer any questions. I just back them down to the other panelists. Yes. So, please go ahead. Please go ahead.
It is about, so we had just had a MPNST, which was involving the pancreatic tail, and was an extensive involvement with subcutaneous, cutaneous nodules coming up in MPNST. So what do you use in these tumors? Because I've tried IA, I have tried gemdosi, and nothing responds. Basically, 2 cycles it responds mildly and then does not. So what is your treatment decisions in these MPNSTs which can happen in these?
I think your MPNSTs behave the way all MPNSTs are expected to behave. Dr. Sameer, you want to take that question? What chemotherapies in MPNSTs? I perceive MPNSTs to be not very chemosensitive. What's your take on MPNSTs?
Yeah, if you want to give IFOS doxo is good. In SARC trials, because they have high topoisomerase expression, so IE also, like IFOS etoposide, if doxorubicin has been given, it can be tried. But otherwise, they are not. Again, if it is neurofibromatosis with MPNST, which might happen in 50% of MPNST, then trametinib works or sulimatinib works. Trametinib works very well, but otherwise they are not chemosensitive.
So again, just to keep you involved, what about hypothermia? We've seen some studies. Regional hypothermia seems to make the chemo more effective. Do you think that's feasible, or that's just studies? And we've already discussed about HIPEC. I think you've answered that question. What do you think is the role of hypothermia?
Hyperthermia, there was a paper in JAMA which combined for extremity sarcoma, but probably it was single arm or something trial, and there was no interest in that trial. I don't know. I haven't heard of this thing other than in sarcomas. We haven't heard of this, and we don't do this, of course.
So yeah, there was a paper in retroperitoneal sarcomas where regional hypothermia along with chemotherapy led to higher response rates to the tune of 60%. But again, I think it's a very select treatment done at very select and very rare centers. So while there is data, I think it's usually something which is not done. So coming to the adjuvant question, would you offer adjuvant chemotherapy to any patient? Would it be a leiomyosarcoma, a grade 3 D. diff liposarcoma? What is the regimen that you use, and how many cycles would you use?
So we use nomograms. In case nomograms shows 50-60%, just like extremity, 60% risk of recurrence, we talk to patient. This is a mere extrapolation. There is no data as such. I cannot guarantee that this will not come or this. And so we just tell them we use 5 cycles. But if nephrectomy has been done, I usually avoid chemotherapy, because if patient ends up in febrile neutropenia, then nephrotoxic antibiotics or ifosfamide or this. So post nephrectomy, though we don't give usually, but we usually discuss with patient and we tell them that see, data is not there, it's just extrapolation. 5 cycles ifos doxo or doxodecarbazine, or
depending on the histology.
Yeah.
Right. But Udip, your thoughts on this question?
Yeah, sorry. So I think we don't offer routinely adjuvant therapy unless the tumors are very big. They've done a CRS. The tumor have involved the vascular structures, and the chances of recurrence may be high. High grade histologies and very large tumors is something that we tend to offer. And post surgical recovery, post surgical tolerance, all of that is taken into picture. And most routinely we will not offer. And even if we offer, then it is a gem dosing 5 to 6 cycles as tolerated by the patients. That is what we give. Roughly 20 to 30% of the patients would be able to take it. Otherwise, I think 70% of the patients don't take the adjuvant. They are kept on surveillance.
Okay. So the last question, and I'm coming back to Dr. Nehal. We've talked about how adjuvant radiation is probably no in most cases. What are those select few cases where you will consider adjuvant radiation, if at all?
Difficult question. Maybe recurrent cases. I would edge more towards giving adjuvant RT. Recurrent, high grade, and large recurrences. Now, I really don't know what is the cutoff of large here, because almost all retroperitoneal sarcomas are large by size. But yes, in these patients, I would like to consider.
Okay.
In R plus resections, yes, definitely. I would not even think before considering RT. In fact, I would like to escalate doses to very tight margins in R plus resections.
So you would certainly consider in R plus resections, right?
R plus, yes. R
Okay.
plus.
Okay, so I think we are running short of time, and therefore I'm not going to go into the metastatic. I think Dr. Sameer did an excellent job, and there's hardly anything to discuss how we treat metastatic RPS. So probably we'll take it up another setting. So I'll quickly summarize and interject me if you think I've not summarized correctly. I think data is very iffy in any setting, adjuvant. I think generally we know that the well-differentiated retroperitoneal sarcomas, particularly the grade 1, grade 2 liposarcomas, recur locally. You know, the grade 3 dedifferentiated liposarcomas, leiomyosarcomas tend to metastasize a lot more than the other subtypes. For a select population of patients, neoadjuvant radiation may be considered. However, the one large completed clinical trial failed to show benefit with neoadjuvant pre-op radiation therapy, but there is some evidence to suggest that in select patients, it does reduce the risk of local recurrence, may be considered in select, well-differentiated liposarcomas. When it comes to neoadjuvant chemotherapy, again, it's in the realm of clinical investigation. But as a medical oncologist, for a select few patients, leiomyosarcomas, grade 3 D-diff liposarcomas, or an occasional synovial sarcoma, neoadjuvant chemotherapy, probably histology-driven, may be considered for 3 cycles. I think the data for adjuvant radiation is very iffy, but we've heard Dr. Nehal saying that for select patients who undergo R1 or R plus resection, adjuvant radiation may be considered. Certainly, it's a no-no for most patients with an R0 resection. And again, for adjuvant chemotherapy, again, it has to be on a case-to-case basis. Select patients may be offered adjuvant chemotherapy if the risk of recurrence based on nomograms is very high. Thank you very much for your participation. I know it's a very difficult subject, but that's why you as experts are here as panelists. So thank you very much, Dr. Sameer, first for the talk and for your inputs. Dr. Nehal, excellent discussion, and then Dr. Udip. Thank you very much. I hand the stage back to Dr. Shefali. Thank you.
Yeah, thank you, Dr. Devavrat, and very nice summarization. I think difficult topic, but very extensively covered the nitty-gritties and the queries which we generally discuss as a routine in the tumor boards every time. So practically. So we'll take up a couple of questions which are there in the chat box, and then we'll wind off. So Dr. Roshni has put, is CT scan better or MRI better for planning surgery in retroperitoneal sarcomas? I think any of you can take this question.
So I think I will answer that. Mostly we would do a CT scan unless you have the disease extending to the pelvis, where an MR would be beneficial. Again, the chest imaging will depend on the subtype, and for most of those subtypes like Lios or grade 3 D-diffs would probably image the chest as well. I think that's what our surgical oncologists tend to do. Right.
And like Dr. Rastogi pointed out, in follow-ups, do you routinely do all the chest CTs and the CT for abdomen, or in select groups only chest CTs and rest the abdomen?
Dr. Sameer, would you want to answer that?
In
Or
well
do you follow?
differentiated, we don't use chest CT, but otherwise de-differentiated, grade 1 we don't see, grade 2 and 3 and leiomyosarcoma we do chest CT as well.
Right. And again, what does that large tumor mean when we see and when we discuss about the resectability? Is there any definition for large? Is there any cutoff, or and how close is the margin when we say close margin? So what is the margin cutoff?
On an average, retroperitoneal sarcomas are 15 centimeter because of expansile nature of abdomen. They are detected at this. So in retroperitoneal sarcoma, I think it is more than 25 or 20 centimeter. Regarding margin, a lot of people have said there are no margins in retroperitoneal. They're always positive. That's what I was in ESCO 2018. And I was talking to some retroperitoneal session that relevance of margin. And everyone just like told me there are no margins. They're always positive. Just that they will recur at different rate. Some of them will not recur, but margins are always positive. That's what they said.
And that's how we should individualize the role of radiation in those settings.
So
Do we
I'll
need
just
to say
come
that,
here.
or should we take it otherwise? So now once we say margins are always positive, what does that mean?
No.
Where do we place?
We have to. Can I come here?
Yeah,
So
please,
we have
please.
to understand the concept of margin in any sarcoma. When you look at extremity, what is the capsule there? It's a pseudocapsule. It's the normal tissue which is compressed. Okay, that forms the pseudocapsule. And if you are beyond that pseudocapsule, the margin is negative. In the abdomen, the pseudocapsule doesn't form. So if you just imagine a tumor which is arising from retroperitoneum, but covering the entire abdomen, the margin will be positive. But the margin that our pathologists look at is not that margin. The place from where it is dissected off the abdomen, that is inked and that is sampled for margins. So if you look at it, they are not covered with anything. So the margin will be positive, as Dr. Sameer said, but you have to, imagine a retroperitoneal sarcoma. And, whenever we plan radiation, we, very much involve our radiologists, our surgeons. What was their impression during surgery? How did they open? How did they reach the base? Where was the pedicle of that tumor? And that is what we contour.
Right. Absolutely right. So
and
I think
just to remind the audience, I think there's a surgical retroperitoneal sarcoma webisode coming up as well. So I think there will be a lot of opportunity to ask these very relevant questions there as well.
Yes, absolutely. And I request you all to take out time to join that session also. It will be really interesting when surgeons discussing or not discussing the role of radiation in close margins or positive margins, where we say always positive. All right. And I thank you all for taking out time and making this enlightening and enriching for all of us. Thank you so much and good night.
Thank you very much.
Bye-bye. Bye.